welcome back. My name is Diane Moran. I'm the Senior Vice President of Strategic Planning for the International Myeloma Foundation. And in 2006, it was my pleasure to start the Nurse Leadership Board. The Nurse Leadership Board of the International Myeloma Foundation works unselfishly and tirelessly on behalf of the myeloma community to bring you the best of education. They do that in the format of seminars, webinars, conference calls. They do it on their own personal time. They give of their own personal gifts, talents, and volition. It is my pleasure to present Dr. Kevin Brigle, who is a PhD on the Nurse Leadership Board. He's from the Massey Cancer Center from the Virginia Commonwealth University. And so Kevin says if you have questions, he's got answers. Kevin Brigle.
Thanks, Diane. So this is a new deck. You guys are seeing it for the first time. And Teresa Maselli, who is on our Nurse Leadership Board, was chair of the group which kind of put this together. It's a rather large deck, and we've kind of pieced it out. And so any comments you have on it would be good to know. It's still a little bit of a work in progress. And again, this is geared toward patients. You have questions, we do have answers. And as Diane said, we have a lot of things which we put on for patients. We also do a lot of nurse education as well. The nurses are taking care of you on the front line, so we do those things as well. So, but anyway, this deck. Okay, the topics. So there's a lot of topics in this, and it says up there, developed by questions from some group members, support group members. When we look at the themes, there are diagnostic testing, test results, and schedule. We're not going to talk about that at all today. That's completely off the board. The treatment options and transplant, just going to touch on that. The big one here is side effects and management. And because that's really, really the big thing. That's what nurses do on the front line, is the side effects and management part of this. And then self-care, clinical trials, and some other topics. I'm just going to briefly touch on some clinical trial thing then as well, because you're going to hear a lot about clinical trials tomorrow. So I thought we would just touch a little bit on that. Okay, a myeloma overview. I am not going to go into a lot of detail on this. Tomorrow morning you have a myeloma 101, and you're going to be reacquainted with myeloma. But again, as it says on here, what do normal plasma cells do? Normal plasma cells make antibodies. They're the good guys in your body. So when you have an infection, they rally to fight that infection. When you get a vaccination, that's where the antibodies come from, are those plasma cells. Unfortunately, like in any cancer, any cell can go bad. A plasma cell goes bad, and it becomes that myeloma cell. And so it then starts to replicate over and over again. It's the malignant cell. That malignant cell then, as it shows there, it produces that antibody, but it just keeps producing that aberrant antibody. You get more and more and more of that antibody, which builds up. That antibody, which builds up, can cause its own problems. Predominantly kidney dysfunction is what we see most often when that antibody builds up. The myeloma cells themselves also just continue to grow and grow and grow. Typically, they grow in the bone marrow. When they grow in the bone marrow, they crowd out the normal cells. They crowd out red blood cells, white blood cells, and platelets, giving rise to those symptoms when we see anemia, thrombocytopenia, the low platelets, and the low hemoglobin, and those types of things in as well. But they also do release some secondary chemicals as well that can cause some problems. So when we think about these cytokines that are released, they start to disrupt your immune system, making you more susceptible to infections. They release another cytokine which activates the part of your bones which break down your bones. That's where we get the osteolytic lesions that come on there as well. So these myeloma cells, they start out as good guys, but just like any cancer, once they go bad, they start to go rogue, go on their own, and start doing a whole variety of things which just are not good. Now, this is the first slide I'm going to put up here, and it says IMF resources for newly diagnosed patients. The International Myeloma Foundation has lots and lots of resources. I know you know about those. We have the seminar today. We have these patient family seminars. We have regional workshops. There are videos, and I've got a couple URLs to videos that are up on the screen that you can watch. But these things are enduring. You can go there any time. You can order pamphlets, whether they're drug-related, whether they're symptom-related, these little cards for tips as well. All these types of things that are available to you from the International Myeloma Foundation. Okay, so treatment-related questions, especially when we're diagnosed, right? We have all sorts of questions. We can start up at the very top with the MIDs, the MIBs, and the MABs. What are those things? So we're all dealing with bortezomib and elotuzumab and all these other things. So how do we get those names, and what are those things? We can go a little bit more specific, and so when someone's diagnosed, Or even if you're in relapse, the question is, what are the new treatments, or what are the latest results, that type of thing, and do I need transplant, do I need maintenance? We heard all those questions today, especially about maintenance. Do I need maintenance? But you have lots and lots of questions, and this is just a small smattering of those questions. So those are some of the treatment-related questions that we hope to answer through these patient-family seminars. When we think about patients being treated, you're basically, if we talk about patients being basically into two groups. You can see up here on the left at the top, it's the transplant-eligible patients and patients who are not eligible for transplant. Now, what makes you eligible and ineligible? There's really, again, no exact formula. It's not age. A lot of it's performance status, comorbidities. Do you have caretakers and things like that? So a variety of things will put you in either one of those groups. When we think about either of those groups, the transplant-eligible or the ineligible patients, everybody's going to start out with initial therapy. Typically in this day and age, for anyone who's reasonably fit is going to get a triple therapy. So one of those IMiDs, one of those steroids, and one of those proteasome inhibitors, typically. So everybody starts out with the initial therapy, and then we move on into consolidation. For the transplant-eligible people, the consolidation is going to be that transplant. And then once you've recovered from transplant, again, that big topic, maintenance. What maintenance do we start? How long do we go into that maintenance? For transplant-ineligible patients, we talk about that initial therapy there as well. Typically, again, going to be perhaps a triple regimen. There's no true consolidation, per se, for patients who are not transplant-eligible, don't go through transplant, but typically we continue whatever that initial treatment is to best response or complete response, and then we taper it down a little bit, getting rid of one of those drugs, certainly getting rid of the steroid, and then we go on to maintenance therapy. And again, how long do we go with that maintenance therapy? Good question. Unfortunately, if you look at the right hand of the slide, what do we see? Treatment of relapse disease. Everybody comes together then. So this is a disease that typically relapses over and over and over. Hopefully our drugs are much better, and that duration of response that we get, that durability, when we have those complete responses or even partial responses, last a lot longer with these new drugs. So those relapse states hopefully are a little bit farther behind. We do have a lot of new drugs. We'll hear about all those tomorrow, so we have a lot more options. The real big thing that I really want to point out on this slide is the bottom part, and that says everybody, everyone. That's supportive care. So supportive care starts at diagnosis and goes all the way to the end. And what is supportive care? Supportive care is taking care of all those symptoms, all those problems, every one of those things that goes on that we're really not using the drugs for. We're using the drugs to fight the myeloma, but how do we take care of pain? How do we take care of neuropathy? How do we take care of those issues with steroids? That is supportive care. In some places, it's also called palliative care. Palliative care sometimes has a bad name. People think of palliative care as being hospice. Palliation just simply means, again, addressing those problems. And so we choose, and most oncology centers now choose to separate that from palliative care. They've rebranded to supportive care, even though they're really one and the same thing. So if you hear palliative care, it really is supportive care. And again, that's taking care of other issues that pop up. MIDs, MIBs, and MABs. There we are. So if you can see across the top, so the MIDs, you look down, those are immunomodulatory drugs. Those are also called IMiDs. The MIBs, those are the proteasome inhibitors. The MABs, those are the monoclonal antibodies. Now, how do they get those names? Well, the FDA really has a pretty strict naming requirement, and so that's why you get these endings on there. Now, the one which makes sense are the MABs, MAB, monoclonal antibody. So that makes a whole lot of sense, that one there. Look down there, we have the new two drugs, the daratumumab, elotuzumab, both of those are IV. We go over to the MIDs, or the immunomodulatory agents, thalidomide, lenalidomide, pomalidomide. Thalidomide, of course, is the drug which started all these new novel agents, kind of gave rise to everything which we're seeing down the line. So those are all oral drugs. When we move into the MIBs are proteasome inhibitors. So bortezomib, carfilzomib, ixazomib. So that's how we name those. And any of them will continue to have all those MIB names as we go down. They're going to end up having those names. Of course, the trade names will be different, but that's how the FDA requires those to be named. So the MIBs are a little bit different. The bortezomib, obviously, we can give IV or sub-Q, carfilzomib IV, and we now have a new oral MIB as well. So we have a little more variety and a little more choices when we're thinking about the proteasome inhibitors. If we look over to the far right, then we call the others. Of course, those are the steroids. We're all familiar with steroids, and we'll talk about those. The older agents, which are the alkylating agents, melphalan, bendamustine, Cytoxan. Anybody who's ever had a stem cell transplant, you've received melphalan. Period. That's what we use to condition patients. So those are the older agents. And we have one of the other new drugs also, which is an HDAC inhibitor, pabinostat. And so all the HDAC inhibitors, the new one coming down the line is varinostat. They're all going to have stat on the end, and that's how we're going to know that they're HDAC inhibitors. And the ones that run across the bottom are drugs that are still a couple antibodies and a proteasome inhibitor, which have not yet been approved but are in late-stage studies. Okay, how do we decide on treatment? And I think Mr. Baru really put this really in great perspective there. Look on the side over there, that nice little graph or that nice little figure. You see clinical experience, data from research, patient preference. This really is an individualized decision, and you take a lot of things into consideration. Number one up there is a clinical trial. If we have a clinical trial available, we always like patients to go through a clinical trial. We always want the next, hopefully the best thing going, a good phase 3 clinical trial for patients who are newly diagnosed, for patients who are farther down the line and have more relapses. We may not have a phase 3, but we may have a phase 2, phase 1 study down the line. But we'd always encourage patients to go through a clinical trial if it's available. So what are the results of those? And again, he pointed out, what about lifestyle and quality? What are the things that I have to do? What are the things I have in the future? And I need to talk to my providers about that as well for when we make decisions. And for patients who have relapsed, what was your previous treatment? So what kind of response did you get? How long was that response? If it was a good long response, can we go back to the TIL? Can we go back to that same agent, those same agents, and go back again? Probably we can, but of course it depends upon what kind of side effects you may have had. So did you have some real bad peripheral neuropathy that hasn't resolved because of that? Then we probably can't go back to that. But we have to look at what you had previously then as well, and again, take it into account those quality of life issues that we have to go through. And again, the really important part that Mr. Baru pointed out too is a consultation with a myeloma specialist. Always, I think it's a great idea to go talk to somebody, and sometimes that's just the point that even if you're with your local oncologist, you'll find out they're doing the right thing. And it gives you some peace of mind there as well. But always consult. I think it's a great idea to consult with a myeloma specialist. So side effects and management. This is the big part. Anyone ask these questions? How do I manage my symptoms? I got bone pain, back pain. The big one up at the top right, steroids, question mark. That's the big one you always hear. Anxiety, stress, some GI symptoms, things like that. And so this is really what we do on the front line, is take care of the symptoms. We do symptom management. Your nurses do symptom management. You talk to your nurses about this all the time, and a lot of your nurses are very good. They can actually answer these questions and help you. If they can't, they go to the providers and they find answers for those things as well. So here's side effects management. Again, you can add lots and lots of questions up there as well. So when we think about symptoms, so we can think about symptoms coming from two things. Symptoms can come from the myeloma itself, which is on the box on the left, or it can come from the treatments, which is the box then on the right. You notice they're not mutually exclusive. You see fatigue coming from the myeloma itself, and you also see fatigue coming from the treatments. So you can cross over. So fatigue can be caused. One thing, you may not get rid of the fatigue. It may start and then it may continue. So those things we have to work on. We look at infection, myelosuppression, things like that. Those kind of cross the board between what's caused by the myeloma and what can be caused by the treatment as well. When we think of those things on the left, the myeloma, you look up there, calcium elevation, renal, anemia, bone pain, everybody recognizes those as the CRAB criteria, right, that we all talk about. So those are the things. And typically, again, those are going to be symptoms that are going to be around right when you're diagnosed. And hopefully when we start treatment, we can get rid of those symptoms. Unfortunately, as you get farther and farther along, some of those symptoms that we get rid of on the left can be replaced by ones that are on the right. And so we have to work on those things as well. So let's look at a nice little table here. Here's the common drugs, and I'm sure everybody in this room has had a few of these drugs, right, and have been exposed to some of these problems that are associated with those drugs. So across the top, we have the drugs, the thalidomide, lenalidomide, pomalidomide, and then the two proteasome inhibitors, bortezomib and carfilzomib. On the left, the neuropathy, thrombosis, myelosuppression, and things like that are associated with those drugs. So when we think about giving patients these drugs, it's one of our jobs to sit down with those patients and talk about the side effects and the potential side effects. So neuropathy, a big one with thalidomide. We don't use a lot of thalidomide anymore, but we sure do use a lot of bortezomib. And so very, very big thing to talk to patients about peripheral neuropathy. And we'll go into peripheral neuropathy in some detail here as well. Thrombosis, blood clots. So DVTs, pulmonary emboli, those are medical emergencies. And so we're very aware of talking to patients about those things as well. Cardiopulmonary things we see there. If you look across the bottom, GI disturbances, probably all these drugs have some sort of GI disturbance, whether it be constipation or diarrhea or nausea, something to that effect. So again, talking to patients about what could occur and how we're going to take care of those things. So setting you guys up to let you know what the problems could be so that you guys can address them ahead of time and let us know as well, and let the nurses know exactly what's going to happen. Of course, some of those side effects as well that you see there are going to dictate or can help dictate what medicines you're going to get. So if someone comes into the newly diagnosed and has a really bad peripheral neuropathy, maybe secondary to diabetes, it's going to be very difficult to give you anything in those that's checked in that top. So thalidomide probably out, and even bortezomib is going to be difficult. So we have to think about these drugs also in their side effect profile, and then the drugs that we're going to give you. Remember, there's no cookie cutter. This is all individualized when we talk about giving people drugs. For some of the newer drugs, the side effects seem to be a little bit better. I think the really important thing which you see up here, or you don't see up here, is that top line, peripheral neuropathy. With these new drugs, we don't see any peripheral neuropathy, which is really nice. These things have been approved a little bit farther down the line, which means everybody's been through bortezomib, potentially thalidomide, and some other drugs which have caused peripheral neuropathy. So a lot of people, by the time their disease relapses, have peripheral neuropathy. So it's nice to be able to use drugs that don't have that as a property and then won't make it worse, and we can continue to give those drugs. One of the newer things which you do see, what you did not see on the previous ones, are called infusion reactions. And those are going to be particular to the monoclonal antibodies. So when you put a protein in your body, it's sometimes recognized as foreign. Sometimes it does its job really well, and you get these type of infusion reactions. They're very easily managed. Myeloma is new to monoclonal antibodies, though we've been using monoclonal antibodies for other malignancies, especially lymphoma, some of the other heme malignancies, for quite a while. Nurses are very good at handling these infusion reactions, but important to let you know that they could have them, because if you do have them, it can be a little bit scary. But the nurses are very good at handling those things. And if you have an infusion reaction, it doesn't mean you can't get the drug. We slow the drug down, you get the drug, those types of things. And it usually only happens on the first or second infusion. After that, it's completely fine. But again, education's pretty important about those things. Again, you see a little bit of the GI disturbance that's going to be common with these drugs as well. So again, I think the newer drugs, a whole different subset of side effects there, but I think they're a little more tolerable than what we've seen with some of the original drugs. So let's get into the big bad guys, the side effects. Now here's the one that bothers us the most as providers, the peripheral neuropathy, and that's because it's really, really hard to manage. Once you get peripheral neuropathy, and I want to direct you to the black box on the bottom there, report symptoms early to your healthcare provider. Nerve damage can be permanent if not addressed, and that is an absolute fact. We really want to know when your neuropathy starts, when you start to get any bit of tingling, when you start to get any bit of weakness, anything like that. That's the most important thing, because we can prevent it from getting worse. If it gets really bad, we have to stop the drug. If we stop the drug, it will not do you any good. We'd rather give you a lower dose of the drug, make it manageable, than give you no drug at all. So that's the one thing, that box down there is probably the most important. When we think about peripheral neuropathy, we think about, probably everybody thinks about sensory neuropathy, the numbness, the tingling, some pain and things like that. There's also motor neuropathy. Patients get weakness. Foot drop might be a thing that you might be associated with that as well. We see some autonomic neuropathy, which is also a type of peripheral neuropathy where people get hypotension, those types of things. But the peripheral neuropathy, the sensory part, is really the part that bothers most people. So again, prevention, the big part. Tell us when it's happening so we can do some things, adjust doses and do some things like that. So adjusting the schedule or the dosing. So Velcade or bortezomib can be given IV, can be given sub-Q. Obviously fewer side effects, less neuropathy when it's given sub-Q. It can be given twice weekly or once weekly. So if you have problems, go to once weekly, and we can dose reduce as well. So we can do those dosing adjustments, whether it be schedule or dose, and take care of those things. So cocoa butter. Dry, cracked skin, that's not going to feel good either. So if you have neuropathy and you have really dry feet, that's going to exacerbate that whole thing. So again, moisturize, moisturize, moisturize. Same things we tell people with diabetic neuropathy. This is no different in terms of how it feels and how we think about managing it. We can take supplements. Try acupuncture, things like that. So some of the supplements would be some of the B vitamins. One of the things we also see is cramping. Who in here has had cramping? Everybody? Yeah, cramping's a big one. What causes it? Absolutely nobody knows. so that's the difficulty with it. So you can see what's up there. So some anecdotal things, we can use mustard, we can use pickle juice, tonic water. Okay, they're kind of a little, again, some more anecdotal things. The one thing that probably does work the most in patients is the tonic water. It's because it has a small amount of quinine in it. When I first started as a nurse practitioner, we could actually write prescriptions for quinine for cramps. Trouble is, it caused cardiac arrhythmias, and the federal FDA said, we can't do that anymore. So a little bit of quinine water, so drinking 12 to 16 ounces a day is often very helpful for some patients. And then the safe environment. So if you can't feel your feet, or you have weak feet or weak foot drop, get that environment safe, get rugs up off the floor, make sure everything's uncluttered and things like that. Same things we tell patients with diabetic neuropathy. Symptoms worsen, we may have to stop the treatment. We can prescribe other medications, such as gabapentin, pregabalin, things like that as well. If it gets really bad and we have pain, opioids or something to that effect as well. There are no actual approved drugs for chemotherapy-induced neuropathy. All these drugs which we use are actually for diabetic neuropathy, and we just kind of use them. We've kind of stole them, but there really are no approved drugs for that. And of course, physical therapy is good as well if we have patients with more of a motor neuropathy. Now here's the one that bothers you guys the most, the steroid ones. And Mr. Brew brought that up well. He had a nice little slide up there. So they are very, very challenging, to say the least. They are the backbone of every myeloma regimen, and it's because they work really well. They kill lymphocytes, they kill myeloma cells. They usually do it, though, you have to have a pretty high dose, and it's not durable, so we can't keep people on them for a good long time, and cells eventually become resistant to it. But these steroids make all these other drugs work better. So that's why you see them in every single one. Now the trouble is, they cause all the problems. And so not just the physical problems that you can see, the steroids affect every single body system, but they also affect, again, the head, the big one, right? So I get a little labile mood, insomnia, things like that. And I always tell patients, I don't care when you take them, in the morning or the evening. Some patients prefer to take them just before they go to bed because they can get to sleep and it doesn't spike till they get up a little bit in the morning. And so they'll do it that way. But think about what you're doing the next day when you take them. If you can have some variability on the day of the week, choose your day of the week. Choose the time of the day, and try to keep that consistent then as well. I just tell them, just find your sweet spot and go from there. It's going to cause some acid, so we take it with food, some proton pump inhibitors, things like that. And again, we have a concern for infection because, again, it does inhibit the other parts of the immune system as well. It can cause weight gain, makes you hungry. Also does a fat distribution, and there's nothing you can do about that. As long as you're taking that steroid, that's just going to be one of those side effects that's going to be very, very challenging. And of course, the other one which can be a challenge is the increased blood glucose. So for anybody who's diabetic, you're going to see your blood sugars go up. So very important to maintain contact with your primary care physician to manage that, and or if you have an endocrinologist would be good too. Diarrhea. Part of the game. So a lot of these drugs are going to cause that then as well. And sometimes you get diarrhea, you get constipation, you can find things alternating. One of the things I always encourage patients to do is bring in all your meds every time. And we can go through those things. Because sometimes you're taking medications that are causing some problems then as well. So these dietary supplements, see up at the top, laxatives, antacids, magnesium, some things like that can be causing the diarrhea, antibiotics, there's antidepressants, and those supplements that are listed there. So we can go through those things with you and see if that can help. I always tell patients to keep their fluid intake up. Of course, that's good because we always worry about kidney function in patients with myeloma then as well. Avoid those caffeinated drinks, and of course there's antidiarrheal medications which are either over the counter or something we can prescribe for you then as well. Always, fiber's a great idea as well because fiber binds up the water, so it kind of makes it more solid. So we don't use fiber just because we're constipated, we have diarrhea as well. So it's a good agent for both. Pain, here's a bad one. So pain, typically, it's going to be the worst right at the start. In fact, 70% of patients are going to present with some type of pain, and so we like to get that under control. Typically, we can get that under control by treating the disease right up front. So the most common cause right up front is going to be that bone disease. And so hopefully when we start the therapy, that resolves pretty quickly. Down the line, we can see peripheral neuropathy causing pain also. So how do we manage that? Of course, medications. Bisphosphonates, Zometa or pamidronate is what we hear. Analgesics, so like Tylenol, we tell patients if they can, please avoid Aleve, NSAIDs, ibuprofen, things like that, because it can be a challenge to your kidneys. And again, we want to protect your kidneys then as well. Increase the activity, that's can be good. Surgical intervention, kyphoplasty if we have compression fractures, so kyphoplasty, vertebroplasty. Radiation therapy in a select group of patients is very good at taking care of pain, but we don't often do that. And then there's complementary and alternative medicines such as supplements and acupuncture then as well. All right, fatigue. This is Teresa Maselli's dog. So his name's Danny Boy because he was born on St. Patrick's Day. So, and I don't know if that's fatigue. That's what my dog does for a job. So so anyway. Okay, fatigue, depression, anxiety. Why are they put together? It's because fatigue generally doesn't exist in isolation. It is really combined with depression and anxiety, and you can see there it's associated with pain, stress, and those types of things in as well. Certainly can affect your relationships, how you interact with your family, how you interact at work. If you can go to work, if you're depressed, you kind of lose that desire to do some of those things. So how do we manage that? For anemia, if you have that fatigue that's associated with shortness of breath, certainly we can give transfusions. Increase your activity as much as possible. And patients, even with bony lesions, can actually increase their activity. There's some studies that have been shown there are very good physical therapy activities you can do, and that physical therapy increases your quality of life, increases your nighttime sleep, and can actually overall then increase your just total activity level. And again, get rid of some of that fatigue and depression that we might have. Proper rest, of course. Support groups is what you're doing today as well. Education, support groups from near where you get your care then also. So very, very important about those things. And of course, I'm bringing this up again. International Myeloma Foundation has lots and lots of information to help you manage all these side effects then as well. And then lastly, I have here clinical trials and other questions. And I'm just going to briefly, on 3 slides here, should I participate? Who has been in a clinical trial? See, not many, okay. But there's been a fair number in there. But okay, should I participate? And all these types, there's a lot of questions about clinical trials. And you're going to hear a lot of data tomorrow. And so they're going to say all this stuff, clinical trial, clinical trial, clinical trial. So what are the clinical trials? They're basically, this is clinical trial 101. So phase 1, phase 2, phase 3. Phase 1 are basically very small studies, sometimes only 10 or 15 patients, usually only at 1 or 2 institutions, and it's the first time a drug has ever been used in a human. And you get those, and those are really trials which are actually looking at can patients tolerate this, and at what level can they tolerate that? We're not really looking for a response in any way, shape, or form. It's worked in the lab. It's killed myeloma cells in the lab, so now can we give it to people? Phase 2 studies they basically build on the phase 1. So we found what we can do in patients. We can give them this, and so now we've got a much bigger study. Typically, these are not randomized. Everybody gets the drug. We're not looking at survival at all. What we're looking for is response. So do people respond? And typically, when we think about phase 2 studies, these are patients who've relapsed multiple times over. They've had a lot of the drugs that are available, and now we need to know, can this next thing work? Think about elotuzumab, which was just approved. Okay, think about daratumumab, which was just approved. Daratumumab was studied in patients who've been through pretty much every chemotherapy regimen. We saw a 30% response rate. Great. FDA loves that, and knows how they get approved. We think about phase 3 studies. Those are the studies then when you're actually looking at standard of care or whatever drug, triple combination, let's say it's bortezomib, Revlimid, dexamethasone, and we add another drug such as one of the antibodies to it and compare that, and do people do better? So those are much bigger studies. Those are usually comprised around 400 or 500 patients, and they're done at multiple institutions. Where do I find these? The Myeloma Matrix on the IMF website is a great place. Second place is to go to Clinicaltrials.gov. You can put in all your information and find a place nearby you that might have those if you're interested in participating. All right, and finishing up here, complementary and alternative meds. So we talked about that, and Sandy Curtin has a little video on, it's actually a slide deck on the International Myeloma website talking about complementary and alternative medicine. She's one of the charter members of the Nurse Leadership Board, and she talks all about supplements and all those variety of other things that we can utilize in as well. So, and that's at least a good half-hour talk. So we're not going to go into that here, but I encourage you to go to that website and look at that as well. Mr. Baru also talked about taking care of yourself. Be a consumer ask questions, be informed. Are you informed? You're being informed today, so you can be informed at a lot of reputable sites. Seek the opinion of a myeloma specialist, and if you don't like what you hear or you're confused, seek the opinion of a second one. But always get as much information as you can. Again, you're going to make decisions in your own healthcare. Healthy lifestyle, big one. Okay. Big one. So nutrition, activity, we talked about the Nurse Leadership Board having these ideas about taking care of ourselves. 10 years ago, patients had a median survival, or I should say 15 years ago, median survival was 3 years. We didn't think about that so much. Now patients are living much longer. Important to do those colonoscopies, breast exams, and things like that, and stop smoking. And I just got the stop signal. So anyway, so here, you're not your cancer. You know that, right? So here we are. Think about these things when you're talking to your primary care provider, talking to your oncologist, the events that you have ongoing, all those types of things that are important to you when you're thinking about making a decision about what type of treatment you're getting, or when your next treatment, or potentially stopping your own. And we cannot forget the caregiver. I like this slide in here. I don't want to talk about it, the whole thing, but you'll see everything on that slide also corresponds with everything that the patient needs. Take care of yourself. You can't be a good caregiver unless you take care of yourself, both mentally and physically then as well. Resources, okay, myeloma website, but also talk to your providers, and then down on the bottom right's the most important one, your nurses. They're your first line of defense then as well. Resources, I brought that up again, shamelessly. You have questions, and this is gonna fly to the last slide. There we go, okay. Questions?
On one slide, you had a side effect of treatment, shingles,
Yeah.
one of them.
Yeah.
Could you please a little bit more specific about it? On the new drug slide, it was no shingles, but rash.
Okay.
Can you please a little bit more deeper explain?
Yeah, okay.
Thank you.
I will. So shingles is a reactivation of that zoster virus. If anybody who's had chickenpox, you've got that living in your nerve endings. And when your immune system gets compromised, you can actually have that those things reactivated, and that's where you get that really, who in here has had shingles? Quite a few, or at least seen shingles. So that breaks out on the skin. So a lot of patients who are immunocompromised, we see it particularly more with the patients who are on the proteasome inhibitors, bortezomib and carfilzomib. So we prophylax everybody on that particular drug. Now, we don't necessarily see it. So when we didn't say no shingles, if you're looking at like the IMiDs, like Revlimid, all the IMiDs, thalidomide, pomalidomide, and Revlimid can cause a rash, but we don't necessarily see increased shingles with those. And so I think that's what that line meant on there. I'd have to go back and look at that. Again, most of our patients are going to be, a lot of them are on a triple regimen, so we keep everybody on a prophylactic dose of an antiviral then as well to prevent that shingles.
Do the fibrates interfere with the absorption of, say, Revlimid or any of the other agents?
Does the, what, I'm sorry?
Fibrates that you said for diarrhea.
For diarrhea, yeah, it does. It can interfere with those. In fact, if you actually read that whole part on there, if you actually read, did someone prescribe the Vibrase for you for cholesterol, or was it?
No, for the diarrhea.
For the diarrhea, yeah. So you're supposed to take any other medication because it interferes with all medications. You should take your other medications at least an hour before you take that, or 4 hours after. Is exactly how the PI reads on that.
Hi. Quick question about us myeloma patients being immune compromised. As I understand it from the slides, one of the things you mentioned is that, I think just simply having myeloma means we're immune compromised. And so the other question is, of course, we have a transplant, we're even more immune compromised. It's about as bad as you can get, I guess. So is there anything that we ever have to look forward to about improving our situation with respect to being immune compromised?
Yeah, you do, and part of it is killing the myeloma. So when you're treated, so the myelomas themselves, the myeloma cells, again, they secrete substances which actually cripple other parts of your immune system. When you get rid of those myeloma cells, all those cytokines and all those things which the myeloma cells are making actually let your bone marrow and the rest of your immune system go back to normal. So once you get rid of those, actually your immune system starts to recover. Same thing after the bone marrow transplant. You are profoundly compromised, but again, toward that, and typically they talk about the 100 days, that you should have a fully reconstituted immune system then as well. But getting rid of those myeloma cells is really, really key to recovery of your immune system.
Well, this will be the last question.
Thank you. Hi. Do you know the difference between the incidence of diarrhea in Revlimid versus pomalidomide or Pomalyst?
No, I don't know that right offhand.
Okay,
Yeah.
I'll look it up.
Okay, yeah. You know, some of these drugs are like, if you take all the studies with bortezomib together and you look at the data on it, and one third of the patients get diarrhea, 1/3 of the patients get constipation, 1/3 have no problems. And I literally tell the patients, it's literally a crapshoot. I don't know what you're going to get. We'll find out the
Thank
first
you.
time,
Thank
and we
you for
go
that.
and we go from there. So.
All right, let's give him a round of applause.